Hey guys, so in this video, I'm going to be covering the hospital admission order sets. One thing that I had forgotten to say in the last video about the problem list is that if a patient's already admitted to the hospital and then they develop a new problem, then make sure you're adding that to the problem list and updating the list. So for example, this patient came in with the CHF exacerbation, and then let's say the second day in, they developed pneumonia. Make sure that you make that a new problem and then put it in the appropriate order on the list. And then also, um, let's say one of these problems resolves, like you replace their electrolytes and then the potassium normalizes. Don't just delete it off the list. You can just really briefly say, when you're doing your note here, just say like present on admission, now resolved. Sorry. And so that's that. And then let me go here. So as far as the order sets, and this is kind of the first thing that I do when I start putting in like admission orders and working on my admission. So as I kind of mentioned in the other video, my go-to one to use is this HOS general admission. The example we're going to be doing is a CHF exacerbation. So there actually is one for that type of admission. If you want to use that, I generally don't use those. And then just to reiterate again, the ones that are like kind of required to use, at least that I've been told by multiple attendings, is these first two, so neurostroke TIA, and then the septic shock one, or just sepsis if they have sepsis. And then let me see. And then, like I was saying, one of the night attendings likes us to use this cardiac admission pathway V2. And so you could just use that whenever you're doing a chest pain admission. All right, so I'm gonna pull this one up, and then I'm gonna try to make the video as quick as I can, but you'll kind of see here, there's a lot of information in this. And then one thing I'll say before I get started too is that I think definitely like medical students should be doing these as independently as possible. There's a lot of little decisions here where you have to use medical judgment. And so I think it's a really good opportunity for learning how like logistics and communication work in the hospital. And then like as you'll see, there's kind of a lot of little things here. And then also once you guys go on and do your sub-Is, you'll probably have to use the computer at some point, and you'll just have to know kind of this stuff. And so you'll really stand out if you know, even if you're using a different system like Epic, a lot of this is universal. Like, every patient, for example, has to have a code status put in the computer, so that's kind of a big thing. So a lot of it's universal, and so you'll really kind of be ahead of the game if you know how to do this. So I always have the med student kind of do it independently, like I'm kind of over their shoulder sitting next to them, so they can do it, and then if they have questions, they can ask. All right, so we're gonna start going through here, and then sorry, and then kind of just talking about each one. So first is the resuscitation status. So it's super important. So if you right click here, it gives you more options of their code status, but that one definitely has to be checked. And then, yeah, like I said, a physician has to confirm it with the patient. Cardiac monitoring. So in the hospital, there's certain floors that don't have cardiac monitoring, like the medical floor. They can't have any patient on a cardiac monitor or telemetry there, but the other ones, the ICU, obviously they're on monitoring, but telemetry, all the patients are on monitoring. Surgery, they can, or it's kind of like a either or. Same with the COU, the clinical observation unit. They can, but they don't have to, I believe. And then the medical floor, they're not allowed to be on monitoring. I'm not sure exactly why, something with the nursing, but if they need to be, then they would need to be transferred to like the telemetry floor or something. So going along with our case, so our patient is coming in with a CHF exacerbation. So, yeah, they need to be on cardiac monitoring. They have like heart failure with reduced EF, and so they could go into cardiac arrest or develop an arrhythmia or whatnot. So yeah, generally, if a patient has like a cardiopulmonary problem that they're being admitted for, then I would put them on cardiac monitoring. And this one definitely go over that with the attending of what they would like. Vital signs, I would just leave this checked. It says per unit protocol, so that's fine. Oh, and then I missed this. So maybe off for activity, that's kind of up to your clinical judgment, whether you feel it'd be safe or not to have it on or off while the patient's say like walking to go to the bathroom. Pulse ox, that one I just leave checked. There's certain times when you might want to do a continuous pulse ox. Neuro checks, if they're admitted for a stroke, you would actually use a different order set for that. But yes, say if the patient has, I don't know, questionable altered mental status and you're kind of monitoring that, or questionable mental status, then you can check that. Let's see, eyes and nose or input and intake and output. So this is where the nurses would measure all the fluid that goes in the patient, like IV fluids and PO fluids, and then all their urine output. If you're not in the ICU, the nurses sometimes don't document this. And then also if the patient doesn't have a Foley catheter, sometimes it's impossible. Like if they're just peeing in the toilet, they can't really calculate this. They could have them go in like one of those hats on the toilet, but sometimes it just doesn't happen. Or if they go in like a brief or a diaper. But so for our patient, I'm going to switch this to every 4 hours. And then you can also ask the nurse if they can be strict with the eyes and nose. And then this patient, I do want to get a weight to see what their base weight is compared to when they discharge, to see kind of how much fluid we diurese off them. And I'm actually not sure what this order is here. I'm going to leave this one unchecked because we'll address diabetes below. And then our patient does not smoke, so I'm not going to check that. This box I always just leave how it is, unless for some reason you want to put in a catheter. Let's see. So going down. All right, so the head of the bed, I always leave this checked. I think it's more important if the person has respiratory issues. So our patient has pulmonary edema, and so you can get orthopnea if you're lying flat. And so it'd be important for our patient to have the head of the bed up. I always just check this automatically on patients because they can adjust it themselves. And then like older people can, like if you feel like they're an aspiration risk, that'd be another reason to really have the head of the bed up. Also, I think it makes them more kind of alert during the day. If they're, if somebody walks in their hospital room, then they can see who walks in because they're kind of facing and they're up and facing the door. This one's important to know, up with assistance. So if you check this, then it puts a bed alarm on their bed. And then that means whenever the weight is taken off their bed, like whenever they get up and out of bed, then an alarm goes off. So this only use if you have to, like if you feel like they're a fall risk. But otherwise it kind of is kind of an annoyance for the patient, and then it promotes them just laying in bed and not getting up, and then that promotes DVTs to form, and then that could lead to a PE. So let's see, for our patient, we'll just say that they're not a fall risk. So we'll say up ad lib. So that's, they can get up whenever they want. And then we're going to check this box. So we want them to ambulate. And then the nurse will kind of, or at least the nurse should kind of encourage them to get up and out of bed at least 3 times a day. And then this helps for 2 reasons. So it kind of reduces the rate of DVTs if they're circulating the blood in their legs. And then 2, it limits kind of deconditioning. That's a term that means like muscle wasting and atrophy while they're in the hospital, which can really happen quickly in especially older patients. And if they're not eating very much, they can lose muscle really rapidly. And especially if they're hospitalized for like a prolonged period of time. So that's important. And then as far as the diet, this patient has diabetes and has heart problems, so I'm going to check both of these. There's another order if, say, they have like a surgery or a stress test the next day, and you want them to be NPO at midnight, you can select their diet, but then there's another order that's called NPO at midnight, and then you can just do that order, and then maybe specify in that order like it's for a surgery plan for like this date, just so it's really clear. Okay, so next are IV fluids. I believe that the normal saline is cheaper, so we kind of favor that one. Like I think in sepsis you want to do LR. There's a few other indications where like for specifically using LR over NS. And obviously for our patient, we're diuresing them. That's the reason for the admission mainly. And so we're not going to give fluids, but just kind of a little bit about this. So there's IV or there's a bolus fluids or just maintenance fluids. So the thing about the maintenance fluids is that you set a rate and then it just kind of stays on indefinitely. And so you have to be aware that they're getting fluids because they can end up with like pulmonary edema, especially if they're older. If you're just kind of like overdoing it with fluid, just a continual drip of fluids. One thing you can do is set this. You can do like a bolus and then change the rate of it. Let's see, modify it, and then change the rate to like a maintenance drip, say like 75. And then, if you're doing this, I would maybe let the nurse know that the rate has been changed, because like I had one time the nurse just saw this order and then just dumped the whole bag at once without setting the specific rate. So maybe make it say specifically you want that rate. But that's one way to do it, to where you give them 1 liter of fluid, a bag of fluid at that rate, and then it just stops. So you don't have to worry about forgetting later. And then 3 days later, you realize they've gotten like 10 liters because it just went on nonstop. Okay, so okay, so next one, these ones are really important. These are all subsets of orders. So VT prophylaxis. So here, there's basically 3 buttons you could potentially click. Like I know there's other ones, but basically these are the go-to ones, or these 3. So if you're doing chemical DVT prophylaxis, you have the option of, I mean, there's other options, but basically the ones we do are either Lovenox or heparin. So Lovenox is a once-a-day shot, and they're both subcutaneous. And heparin is 3 times a day or every 8 hours. So that's one of the biggest things, and that's the reason why we favor Lovenox. And so pretty much we're generally going to put patients on Lovenox in the hospital. So one thing with this though is you have to keep in mind their kidney function. So if a patient has a creatinine clearance, and that's one of the ones that you have to calculate like on MD-Calc. So if you notice, say their creatinine's elevated, then go ahead and calculate their creatinine clearance. And then if it's below 30, and you can look this up on UpToDate, but if it's below 30, then you'd want to lower their dose down to just 30 milligrams once daily. And then if the patient is on dialysis, then you want to go and do heparin instead. There's an UpToDate kind of touches on this, but there's some studies that show that Lovenox is safe in dialysis patients, but UpToDate basically says there's limited data on it, so they're not comfortable recommending that. So basically, if they're on dialysis, then do heparin if you're going to do one of these. And then if the patient, sorry, so if the patient has a reason not to be on chemical DVT prophylaxis. Say they have an active bleed, like they're being admitted for a GI bleed, or their platelet level is just super low, so they're at risk for bleeding, or like if they did have a bleed, it would just be a terrible thing. Then let's see. Then you're going to go ahead and do SCDs instead. So what these are, and I know it's spelled differently here, but SCD stands for sequential compression devices. So what they are is things that go over the calf area, like the lower legs, on both legs, and then they kind of like sequentially squeeze. So it kind of mimics like walking, like the muscles contracting, and then it kind of pumps the blood through, or promotes circulation of the blood. And so that's kind of an option there. And then if you'd like, you could click these. I've kind of been told that it's not absolutely required to like document this. Some of the attendings might want you to, but I generally don't do that. So yeah, basically with this tab, click one of these three. Generally, you're going to go with Lovenox. So for our patient, I'm going to do Lovenox, and the patient's creatinine in our example is fine, or their renal function's fine. So we're just going to go with the full dose of 40. Let's see. Okay, so next, and our patient does have diabetes, so you'll select this one. For this one, anything that's checked, just leave checked. And then any patient with diabetes, like almost always, I've never seen a case where you don't do this, you put them on a sliding scale. So that would be this correctional insulin. The last video in this series is going to be on diabetes, so I'll do a super in-depth lesson kind of on this. But these first three here are the sliding scales. The last one's a custom one, but so this is low, medium, and high. They're popped up, so high sliding scale. And then, so let's say this patient has kind of more mild diabetes. We're going to start them on a low sliding scale and then kind of go from there. So you click this, and then there's two options. CCHS means with meals and before bed. And then this one is at 6 a.m., noon, 6 p.m., and midnight. I believe that's what it is. And so both of them, the nurses check the blood sugars 4 times a day or every 6 hours. So both ways they're getting checks. But then this one is like if they're eating a normal diet and everything, then they do it like with meals. Whereas this one, say if they have a peg tube and they just have continuous feeds, then you're going to click that one. So I'm just going to go with the normal CCHS one with meals and before bed. And then I'm just going to leave everything else checked. So, okay, then the next one. So this tab, it's got a bunch of kind of random things on it. Our patient, we'll start from the top. So these I just always check because it's basically like if this is happening, then the nurse is allowed to do something. So yeah, obviously if the patient's hyperglycemic or hypoglycemic or showing signs of that, then I want the nurse to be able to take action and check the sugars. If the patient hasn't urinated in 12 hours, yeah, I want the nurse to be able to do a bladder scan and then let me know. You can check this one. I generally don't. I'd rather have the nurse call me and ask what the post-void residual is on the bladder scan before putting in a straight cath, just so I'm aware of what's going on. Our patient doesn't smoke, so they don't need that. And then this is important. So this is a parameter that I would say every patient needs to be on as far as a blood pressure parameter. So if their blood pressure, what this is if their blood pressure goes above a certain number, then the nurse will automatically give one of these meds. So the number that most hospitals use and that we use is 180 for systolic. So there's two options. Well, there's probably other ones, but the only one they have here is hydralazine, 10 milligrams IV, and then the other option you could do, and I think for the most part this is a perfectly fine option is losartan. I believe it's losartan 10 milligrams IV. I don't prescribe that one a ton, but generally though, this one is fairly safe, so we're going to put the patient on this. Know that the kind of thing to know with this one is it can cause reflex tachycardia, just kind of in response to lowering the blood pressure abruptly. And so keep that in mind if the patient's blood pressures jump up after giving it. Or if the patient, and that could be a reason also like not to use it if the patient comes in and has AFib with RVR and you don't want the heart rate super high, you could go with PRN, or sorry, did I say losartan before? I meant labetalol. PRN labetalol is the other option. You could go with that instead. Let me see. So next is our nausea medications. So generally you wouldn't do both of these, you would choose one. And then something really important with this is that both of these medications can cause QT prolongation. So if it's someone, so like our patient, they're older, they have heart problems. Before you would start them on one of these, I would probably get a baseline EKG. Generally, like the ER is going to get one anyways with this type of admission. So look on there and look at the QTC. And then if it's elevated, then be really careful if you do give one of these. And then you don't necessarily always have to check these boxes. Like if the patient's complaining of nausea, the nurse is going to call you and then you can just put in for a one-time dose of it. So if you don't feel comfortable with the patient having availability to these meds like every 6 hours for the whole time they're here, then just don't check it. And then, you know, if it comes up, then you can take care of it at that point and make a decision. For this one, I always just check, and I'm going to check Zofran for our patient. For this one, I always check Tums. I don't know if there's too many contraindications to using that. I feel like it's a pretty benign medication. Obviously, if their calcium's elevated, you wouldn't give it, but I think it's pretty safe to take Tums. GI prophylaxis. I know some hospitals put just all their patients on this, kind of like how we put all our patients almost on DVT prophylaxis. With this, you could consider this if the patient is on, say for some reason you're giving a bunch of NSAIDs or you have them on steroids, like if it's a COPD exacerbation or like an asthma admission and you have them on a bunch of steroids, then you could go ahead and click that. At the same time, a lot of patients, I feel like half the patients we see here are already on a PPI, so you don't have to worry about it. And then next is constipation. So there's two options for this. There's either PRN or just putting them on a bowel regimen where it's scheduled. There's studies that show that that Docusate has like basically zero efficacy and it's kind of pointless to give. The two that I commonly use are Miralax and Senna. And then you can decide whether you want to give them scheduled or PRN. If the patient's coming in, say for a hip fracture, and they're on a bunch of opioids, then I would probably put them on a scheduled, like Miralax BID. You could even do that with Senna or something if they're constipated or if you think they're going to get really constipated from the opioids. And then if the patient smokes, then put them on a nicotine patch. For some reason, these aren't PRN, so you can just right click. Let me see. Oh, you have to select it, and then you can right click and then switch it to PRN, just so the patient has a choice. And then for our patient, I'm going to order PRN Miralax. That's kind of my go-to. So the ones that I selected are kind of the ones that I kind of generally just click automatically on most people. So next is pain medications. My go-to for this is just selecting Tylenol. There's very few reasons why you wouldn't use this. so like if they have end-stage liver disease, you generally wouldn't. And then if they have like extremely elevated LFTs, something like acute hepatitis, you might want to hold off on these. But even if someone has cirrhosis, I believe you just go with like a lower total daily max of this, like 2 to 3 grams. You'd have to look that up, but yeah, most people though can handle Tylenol. And then generally we don't give access to the ibuprofen like this. If they have a headache, then I'll do it like a one-time dose. But because most people we're admitting are older, and we don't want to have them develop a GI bleed here. And then you can use these as well, but most of the time you're not going to start somebody on a pain med or an opioid. So let's see. So going down here, I've never seen anybody use this vaccination one. Electrolyte management. So the second to last video in this series is going to be on electrolyte replacement for magnesium and potassium. So I'll go into that, but basically on the floors, meaning not in the ICU, at least in our hospital, the doctors just do this themselves. In the ICU, I've seen that the nurses kind of handle electrolytes. So basically, don't click this unless you're in the ICU. It's kind of the short answer. And then that takes care of most of this stuff. So other than those that I've talked about, just kind of click whichever ones. I mean, most of the time the ED is going to do like a fairly thorough workup and order most of these labs. But these are just labs you can click if you want them ordered. And then I'm going to order morning labs for this patient, just a CBC without diff and a BMP. One thing to keep in mind is if you're admitting the patient after midnight and click these, then they'll be ordered for like 2 days in advance or the next day and not the next morning. So you have to go in and change the dates. But yeah, that'll order them for 6 a.m. the next morning. You can order cultures, other tests here. And then let's say we're going to get an echo because this patient's got CHF. And then this box is automatically checked. I would never uncheck this just because we want the nurses to be able to give oxygen if the patient needs it. So I would just leave that checked. Let's see what else. If they're on CPAP at home, you can do that. You can kind of read through these, but yeah, these are consults to PT, OT, speech therapy, if they have like swallowing problems, wound care, case management is a big one. So kind of just click whichever ones you feel like that they need. Let me move this out of the way. So I think that's it for our patient with the CHF exacerbation. Let me go back. So, all right, so we put in those orders and then click initiate now. And then for some reason you have to click this button like 5 times. And then order anyway. And then after this, then place all the other orders that you might need to place. And then what I always do is, and I would definitely always do this, but go down to the MAR and then just make sure that all these meds that you just prescribed are on the MAR and like scheduled for the correct times. So all of our PRN meds are there, and then there's the DVT prophylaxis. So yeah, hopefully this video is helpful. There's a lot of points here. And then again, kind of, I think this is good to go through as a medical student and really understand kind of all these points. Like DVT prophylaxis is a really basic hospital skill, and it's not super complicated, but just kind of knowing when to use that and which medications to use. So, all right, that's it for this video.